HIV, oh, was muted, sorry. Once HIV was entered into the community, there was a rapid spread, as you can see. And syringe sharing was really at the heart of what led to this epidemic, and the lack of syringe exchange services in that area, and a slow response to bring in those syringe exchange services. Okay, there we go. All right. Have we seen a change in testing in PWID? So we hadn't really been targeting PWID for frequent HIV testing in our community, given the lower numbers. However, over the trend over the past few years, up until this cluster that we've identified, it had been fairly steady, according to the NHBS data, where we've seen about half of people or so getting tested who are PWID. So there's not really an increasing in testing that explain this increase in numbers in the past year. We also know nationally that from data, not just here in Washington State, but overall, that the percentage of PWID who have HIV have lower rates of virologic suppression. So we're a 90-90-90 city, right, or county, and we have really made huge strides in treatment of HIV and getting people retained in care and treated. However, people who are non-MSM PWID have lower rates of suppression, as well as MSM PWID when we look at all comers. So 87% versus 79 and 80%. We also know that the mean time to virologic suppression is longer. So we have a longer period of time where people are have potential for transmission to others. And so non-MSM PWID, days to virologic suppression is pretty long, 262 days to get virologically suppressed, compared to some of our patients that we see at Madison Clinic, where we get them on therapy and they're quickly suppressed within just a couple of months. We've also seen increasing methamphetamine use in patients in people who have traditionally just used opiates. We've seen a rise in heroin use and concurrent methamphetamine use. So here you see over the past 5 years or so that we've seen a significant rise in PWID's use of methamphetamine. And most of the patients that we're seeing at She Clinic that I'll talk to you about do use both methamphetamine and heroin, which is thought to be a risk for HIV as well. So that's what's called goofballs when you combine them together. And Sarah Glick had presented data about how this was associated with potential increase in in HIV. So this is data from syringe exchange programs and NHBS data, which shows that when they asked about any recent meth use, and as you can see, it's pretty high for those who are using syringe exchange services or were surveyed with the NHBS data. It's close to 90% of people were using methamphetamine that utilize those services. And you can see in non-MSM PWID, it's been a huge increase in methamphetamine use in our community. So there is evidence of equipment sharing between MSM and non-MSM who inject meth. And you can see here that in MSM, the proportion that report equipment sharing is over half. And so these are our people that are highest seroprevalence. So as we know, there's up to 20% positive in that community. And then when we're seeing them sharing with the non-MSM community, that's where we see this potential for transmission of HIV, which is what we're dealing with currently. So that brings us back to where we are now and what we're going to do about it. So we're fortunate that we have a very robust public health team that was investigating and identified this cluster pretty quickly. But we learned from Indiana that we need rapid response to HIV cases when we do identify clusters and communities that had previously not been at risk. We know we need syringe exchange services and expanded use of buprenorphine and other opiate agonist therapy. We are actually a pretty resource-rich county in that sense that we've already had a lot of syringe exchange services. It's just getting them out to where we need them in the community. So these are the counties identified as vulnerable based on that modeling study that I presented earlier, that I talked about earlier. You can see that there's no red or blue up in our area. And, but I think this is why this is, I think this really underscores that we are all vulnerable. So many areas are vulnerable, not just the ones indicated here. Even though we are a 90-90-90 community in terms of our successes, we still have pockets of people that we are not reaching well. And every community needs to figure out how we're going to reach those populations that have not accessed traditional healthcare models. So Aurora, for those of you who are familiar with Seattle, most of you in this room are in our geography, up on Aurora and 90th, there is a lot of activity. There's a lot of homelessness. There's a lot of opiates and the street opiates, heroin, and now HIV, and there is sex trade as well. Most of the sex work that's done is exchange sex, which is different from commercial sex, I would say. Exchange sex is really exchanging for food or shelter or any goods that they need, heroin, whereas commercial sex work is more, there is an income that could potentially be made, and there's not necessarily the trauma that's involved with exchange sex. However, there's still a lot of trauma. The exchange sex that occurs is primarily on the street versus commercial sex work can happen on the internet. So there is a difference in that community. So homelessness, we see a lot of homelessness in Seattle. We've had a rising number of unhoused individuals, and I'm sure all of you heard or have heard about this piece or read about this piece or saw this piece called Seattle is Dying. How many of you have heard about that? Yeah, there was a lot of backlash about this, and our way that we perceive people that are living unhoused or people that are opiate dependent. I think most of us in this room or listening are fairly compassionate about this population, are trying to work with this population and improve their outcomes. But there's definitely, I think, a splitting, which was also discussed, where we have a lot of people who have and then a lot of people who have not, and how that's become much more of a disparity over time as we see these communities growing, these homeless communities growing, and the feeling that they're encroaching on other people's communities, whereas we really need to step back and say these are all of our neighbors and not others. So exchange sex, there's not a lot of data locally in Seattle about exchange sex, but we do have some data nationally that did include people from Seattle. There was an NHBS survey done in 2009 that was published in 2017, and there was currently, Sarah Glick and others have just finished doing the NHBS cycle for this as well recently. They surveyed over 2,300 women who inject, and 39% of those women reported exchanging sex for drugs in the 12 months prior. And they also noted that the women who exchanged sex were more likely to be homeless. They were sharing syringes, have multiple partners. So the majority of women had greater than 10 partners, and then about 10% had greater than 100 partners in the last year. And then there was, in this NHBS survey, there wasn't a link between exchange sex, saying you were engaged in exchange sex, and a higher risk of HIV. But what there was that there was a higher risk of being HIV positive unaware. So the women who were positive were less likely to know that they were HIV positive, and they were obviously exchanging, they were sharing syringes and exchanging sex with multiple partners. So Seattle here, you can see in terms of the percentage, so 39% overall, and you can't really see the graph here, but about close to half of women who are PWID in Seattle that were surveyed did report engaging in exchange sex. So we know that there's an overlap of injection drug use and exchange sex, and that increases STIs and HIV. We know that there's an increasing number of women engaging in transactional sex in the Seattle area. And you all know, you may know that last year, right around the time of the cluster, and I'm not saying that they're correlated at all, but there was the shutdown of the back pages, which many women were using to solicit to advertise services for sex. And that was shut down, which actually led to more women being on the street to engage in sex work. And also for the women that were already on the street, that was more competition, and they were having to engage in higher risk sex, condomless sex, and multiple sex partners, because the value of their sex services had gone down because there was more women out on the street competing. So we come up to our cluster, and the initial murmurings of what was happening with this and community outreach. So there, I'll go through the timeline that I got from Matt in a minute, but there was a swift response in public communication about this cluster, which I think was really key to potentially averting new cases. So on August 3rd, disease investigators identified 3 linked cases in North Seattle. By the 7th, public health alerted medical providers and contacted ED directors to increase HIV testing in the emergency room setting, which was not being done routinely for PWID, and to work with other community partners and CBOs to really educate the community about the risk of HIV and to expand testing. Public health deployed a lot of people to do outreach testing and rapid testing. And one of the sites was at Aurora Commons. There was also an expansion of jail testing, because like I mentioned, most of these people are not engaged in traditional medical care or seek traditional models of, or seek those medical care in traditional models. And so trying to reach them where they are. And one area is that they do go in and out of jail, and using that as a resource to expand testing. So this is data from Matt Golden about the characteristics of the newly diagnosed non-MSM PWID in 2018, and the cluster in North Seattle, which I'll focus on for the rest of the talk after this. Rates of virologic suppression were low, and this is not surprising based on other data that we have nationally and locally. Interestingly, there were more women than we're used to seeing. So we know from prior years, epidemiologically, we really are focused more on MSM populations, but interestingly, this cluster had a lot of women. And predominantly white, which is our area, speaks to our area, but more Black identifying patients than in the North cluster than in usual, but these numbers are really small. And you can see that heroin plus meth use was the majority of patients did note heroin plus meth use, and 100% were living homeless. And 83% noted that they were engaged in exchange sex. I will note that from working with these women, they're not necessarily forthcoming about whether they engage in sex, and it's over time that you can get that information after building some trust. So initial surveys can underestimate the percentage of women who are engaged in sex work. So this is where we are up on Aurora. So actually not very far from Northwest Hospital, but they don't seem to access it unless they're in dire need, and near Northgate in the Greenwood area. So this is a picture of Licton Springs, which was a tiny homes community just in that area where the outbreak first was noted. It was basically for a large number of people that were living homeless to give them some sort of housing option. And many of the patients that we are seeing at She Clinic were living at Licton Springs. Unfortunately, it was closed down, and those people were either pushed out onto the street or found other housing, transitional housing. But what we did note in that area was that there was limited syringe exchange services. This was not a community that had been known to be at risk. Our syringe exchange services were located downtown and in the U District, but there was not really a whole lot going up on Aurora. And we know that there's a lot of homeless individuals up on Aurora, and then, as I mentioned, a lot of sex work, and then a lot of stigma, and I think this is really recognized, the amount of stigma of these populations up there. And their stories are really telling, their individual patient stories are really telling about feeling invisible to the community and feeling very neglected, but then also feeling very judged when they're seen by providers. So specifically, the women of North Aurora. So we actually happened to, the cluster had nothing to do with our establishment of the She Clinic. We had actually already been working to establish that for a few years. And so when we established that in July, and then the outbreak was identified in August, we were in prime position to try to offer services to these women, and particularly offer prevention services to these women. But we had been working with the community to try to provide healthcare to these women who were really not in care and we felt like could be at risk for HIV. We didn't really know when we started this project, but we wanted to find a way to empower these women to get on PrEP, but to also get STI, HIV testing, and just general medical care. From working with the Aurora Commons, which I'll talk about as a nonprofit day space, they had done some qualitative work looking at these women who exchanged sex on North Aurora and found, and this was a survey in 2014, that all surveyed were opiate dependent. And so these are women that are coming into that day space. None of them really had a medical home or a PCP. And their prior interactions with the healthcare system were felt to be very judgmental and stigmatizing. So it was a disincentive for them to get into medical care. When we looked at this in 2017, prior to launching the She Clinic, we surveyed the women, and most of them wanted full primary care. They wanted someone who was committed to taking care of them longitudinally and meeting them where they are. And we gave a survey and we've asked them to pick the top 3 things that were, and nearly everyone just circled everything on the sheet. So it was really telling. They wanted I was surprised that they wanted vaccines, but they wanted everything. They wanted contraception, vaccines, cancer screening, mental health care, opiate agonist therapy, STI testing, HIV testing, Hep C testing and treatment. And almost none of them had even heard of PrEP. And so we felt like at that time in 2017, when we did this, that we had an opportunity to provide care to these women. And we partnered with Aurora Commons. So those of you who don't know what Aurora Commons is, it's a neighborhood living room, and it was opened in 2011. It's really embedded in that community and has strong relationships with the people in that community. When we started this, about over 140 women access services at She Clinic. Now it's up to over 200, close to 250 unique women that access services at Aurora Commons. They had been partnering with the Puget Sound Christian Clinic medical mobile van. This was prior to Medicaid expansion, when almost everyone there was uninsured. And the van would come and just do some basic things to connect with the women there. They offered just wound care, foot washings. And actually, that's mostly what the women got, was foot washings. And it was an opportunity for them to just connect with the healthcare provider and talk about their needs. Unfortunately, because they weren't insured, there wasn't a lot of care that they could provide outside of that. And they would be referred to other clinics. And with talking with PSCC, most of those, 99% or more, would not actually go to a clinic that they were referred to, because it was a barrier to leave that area to go to a brick and mortar clinic. So we, with all this data and the resources that they had already brought in at Aurora Commons, we started the She Collaborative. And the She Collaborative is really under the umbrella of Aurora Commons, which is the linchpin. We would not have been able to come into this community without having a partner who is already embedded in the community and has existing trusted relationships with the women there. We know that because public health had a van just a couple of blocks down the road that they had not been accessing. And that was for fear of stigma and just not sure that their healthcare needs would be met. Even though public health had really tried to engage this population, they just did not have that connection with Aurora Commons to essentially have women walked on to the van to see us, which was key. So it began in July of 2018. It's a walk-in model. Anybody can come in and see us that's female identifying. And like I mentioned, it really does take a village to make this happen. It was a partnership with Aurora Commons, PSCC, which lets us use the van, the city of Seattle, which funds the van to be there for us during the times that we're there. DOH, which has been generous to support a full-time medical case manager, my time, Maggie Green, who's the other provider's time, and then a pilot grant from the PHPDA, which is now the Health Equity Fund, to start this project off. And they've actually given ongoing funding to expand the clinic, hopefully. And it's really, we wanted to give what the women wanted, which is primary care for the women of North Aurora. So we did an evaluation of the first 50 patients. So Janelle, Maggie, Green, and myself reviewed charts, and for the first 50 patients, just to get a snapshot of what we were seeing. High STI risk, which is not surprising, but none had been tested in the prior 3 months. And most of them had not been tested for more than a year prior. 29% reported of the women reported condom use, but I would say this is a really leading question, and it's even though we'll ask how do you protect yourself rather than do you use condoms, women are not really forthcoming about their risk when talking about it, and it's over time we sort of ask it in a way that's less likely to be judgmental, or they perceive it to be judgmental, meaning, has anyone ever forced you to have unprotected sex or paid you more money to have unprotected sex, because that's less judgmental and kind of putting it on the person who's soliciting those services. None reported planning for pregnancy, but we had 4 in the first 50 patients who were pregnant. And then now we're up to 10, and which is pretty astounding. 42 of the first of 50 were tested for HIV by us. Others were tested by public health in the outreach. And 17 of the HIV negative women did initiate PrEP at their first visit. And it was really because there was a lot of community engagement and public health engagement of the community to say, you are at risk, there is HIV here, let's figure out a way to empower you to protect yourself. 7 HIV positive women have accessed She Clinic services. Not all of them have been tested through us, some of them through public health. 4 were diagnosed at the She Clinic. 6 are in care and 4 are undetectable. And this, I just checked this yesterday, so this is up to date. 1 intermittently in care, but has not started ART and is not ready to start ART. So as this really does align with what kind of nationally what we're seeing, this is a harder group to reach. And for the women who did become undetectable, they took a long time to get to undetectable. Some of these have just become undetectable recently, despite being diagnosed back in December. So tough to get to this population. Here are some characteristics. The average age is 37, predominantly white, but we do see 22% Black, and then almost all of them, so nearly 100% unhoused. And we can just see the percent positive. Not everyone was screened or declined screening or left without giving a urine. So we don't have comprehensive data on all the first 50 patients. But we do, for the people that we did test, we see high rates of STIs, and mainly trichomonas, is nearly half the patients had trichomonas that we tested. And so we're definitely seeing a lot of STIs. We see a lot of Hep C as well. I'm going to try to move this again to show you that, and these are of the women tested, 40% nearly have, and this is chronic Hep C, so not just antibody positive, but RNA positive. Oops. In conjunction with that first 50 patients review of the She Clinic, Janelle Stewart and Kate Stadelli, who is a surgical resident, actually went out and interviewed a lot of these women. So they interviewed 76 women at Aurora Commons. Not all of them were actually engaged at She Clinic. So we were able to look at She Clinic patients and non-She Clinic patients. And what we wanted to do was look at whether we were having some sort of impact. And she reviewed actually their ER utilization, whether they were going to seek emergency services pre-She Clinic, and then if they were in She Clinic, post-She Clinic, to see if their use of the ED went down. We also looked at Suboxone prescriptions and PrEP prescriptions. So 78 women were surveyed. 44 of those women had been seen at She Clinic. Only 11 of those women reported stable housing. So really, this is a very vulnerable group of women who are living on the street or living in motels day by day if they get enough money to stay in a motel by working pretty much all day and all evening to get a motel. High rates of ED utilization. 71% had been seen in the ED within the last 6 months. And I will say, I think there were about 300 ED encounters for these women. So lots of ED utilization. Only 45% reported exchange sex. And again, this is an issue with trust and their willingness to answer these questions, because when we ask it in a different way, if if they believe that the majority, but they believe that the women around them were essentially engaged in exchange sex, and 89% believe that the majority of women are engaged in exchange sex. So there's definitely a disconnect and a reluctance to admit in engaging that work. There's a lot of shame and stigma around it. So the results here are similar, so predominantly white, but we can see that there are actually more African American or Black women in the survey results that Janelle and Kate did. Medically insured, almost all of them are insured, which is great. This really speaks to how much of an impact having expanded Medicaid in our area is, and how critical it is to serve this population. As I mentioned, 42 of the 76 were seen at She Clinic, unstable housing, 86%, and like I said, those numbers that they believe that they were higher. Recent injection drug use, so 83%, so 44 of the 76 did report they were injecting drugs in the last 3 months, and 75% actually noted recent goofball use. And we wanted to really look at that because of Sarah Glick's data on goofballs and increased risk potentially. This was a self-reported STI, and so most of the women do report that they have STIs, and that is consistent with what we're seeing as well, that they do have STIs. So I'm glad that they are acknowledging that, although many of them did not have testing recently, as I mentioned. Oops. And this speaks to that as well. 74% of the women reported recent STI testing, and those were really the She Clinic patients that we saw mostly that were getting STI testing compared to the non-She Clinic patients, which was only 65%. Recent STI treatment at She Clinic, almost a third of them had recent STI treatment, whereas only a small number of the non-She Clinic patients did. Only 8 were using LARC, or long-acting reversible contraception, 4 at the She Clinic and 4 at the non-She Clinic patients. I will say that most of the women do not want to get pregnant when you ask them, and when you ask them right after, what are you, what is your plan for contraception? They don't have one. And so there is this disconnect of, and they actually, a lot of them do decline contraception. They decline IUD or Nexplanon. So it's a really interesting disconnect. And most of the women that we've seen have children, but they're not in their custody. And I was just talking to Julie about this yesterday, that this is an area of significant trauma for them. And reproductive issues are very sensitive to discuss. And it takes a multiple visits and a long-term relationship with these women to really address that, which is why we've had 10 pregnancies, because we haven't been able to get there with them. So as I mentioned, the 17 women were prescribed PrEP. I will say that none of them are taking it right now on recent review. And it is really interesting talking to the women about taking PrEP. Back in the fall, there was a fear that was motivating their use of PrEP, and they were all for it. And now their fear is less intense about it, and they don't want to take meds every day. And they also have a hard time keeping their meds on they don't have any place to put them. So it's not a priority. This is definitely not a healthcare priority as it was in the fall when there was a lot of fear. We're still encouraging PrEP. And I noticed a recent billboard right near Aurora Commons that from Public Health that says HIV is here, and get checked, get prevention. So I'm glad that showed up recently to remind people. one of the big things that we do at the SHE Clinic is actually address opiate use disorder and opiate dependence. I think that is, as I mentioned, that is probably that and homelessness are really what are driving this, these outcomes. And we can't do anything about housing as a clinic, but we can address opiate use disorder. And this is annoying, but I'm going to move this up here. We have, and this is just in the patients that were surveyed, about 50% were prescribed opioid replacement. And I would say that's the #1 reason why people have ongoing visits with us is for buprenorphine. And the level of engagement with buprenorphine is variable. And I would say that if you use a metric of abstinence from heroin as an outcome measure for our women, then we have no success. But I don't think that that's the measure that we will use. We're working with Caleb Bantagreen to try to evaluate our outcomes. What we've noticed is that all the women say that are on buprenorphine are using less. And that means that they don't have to work as much on the street. That's what they're telling us, to make that money. And when they do make money, it's to actually just pay for a motel room rather than buying heroin. And so we are trying to evaluate those outcomes to really see if we're having an impact, because our UTXs are going to be positive for opiates. And I don't think that that's going to change. Here. This is the ED utilization data that Janelle and had gone through. And essentially, 60 women accounted for 264 ED visits in 365 days. That's a lot. And this is really to try to identify the kind of the costs to the system to help us get continual funding for our clinic, essentially, because if we can avert all these ED visits by having people in care, it would make a huge impact. So on the left there, you see ED visit rate before the first SHE Clinic visit per 100 days. And the bars just say, the first bar is 0 visits, and this is rate per first 100 days. And you can see after that, that the ED visits are essentially the bar that 0 visits went way up. So that just shows us that women are using the ED less once they're engaged in SHE Clinic. And there were some outliers that were using the ED a lot, which is why we have the 60 women accounting for 264 visits. What we're in the process of doing is actually identifying what they're going to the ED for and sort of categorizing that, because even after engaging in SHE Clinic, there's still a fair amount of ED utilization for sexual assault. And like I mentioned, a lot of the women are very fearful of the more traditional models of healthcare and feeling stigma. So they will wait until they're really, really sick to get into the hospital, where their abscess has to be drained in the operating room, or they've got an epidural abscess, which happened recently, or septic arthritis or endocarditis. They're really waiting until they're quite ill to come into care. So essentially, the women up in our North Aurora area are living unhoused and exchanging sex, and they're high risk for STIs and HIV, and they have frequent contact with the ED providers. We have created a co-located clinic. We were trying to come up with a name because it's not really mobile, even though we're in a van, because we're just parked outside of Aurora Commons. So it's really about the co-location that has made it a trusted, safe space for them to come to and engage in care. And we hope to show that we are reducing ED utilization, and in our forthcoming evaluation to really show our outcomes with buprenorphine on the community. We're going to continue to look at, encourage PrEP use, and then STI screening we're going to continue to offer. One of the challenges in this population is that they don't have a phone, they don't have a stable place where they're staying. So when we diagnose them with STIs, we can't always treat them in a timely manner, and we're dependent on trying to find them. And we're only a 1-day-a-week clinic. So we are really, we're looking for opportunities to do point of care testing and reaching out to people to see if, because there are some new platforms and technology that would allow for STI testing within 30 minutes, which would be great. Our plans are to expand to 2 half-days a week, pending funding from DOH, and then to continue to offer low-barrier buprenorphine and optimize its delivery. There are some data that our Kayla Banta-Green has put together, and I think it's about to be published from their work with low-barrier buprenorphine in through the syringe exchange programs to show their success so far, and we're hoping to model it after that. We want to partner with Hepatitis Education Project. We are piloting our first Hep C treatment at She Clinic, and it's just a pilot to see if it'll work. Because it's, as I mentioned, it's really challenging for these women to keep meds on them. They are very vulnerable and get things stolen all the time. But if we can partner with a group and see if we can try to provide intensive outreach to them for those 8 weeks on treatment so they can get treated, it would be ideal, because as mentioned, there's a lot of syringe sharing, and about 40% of these women have chronic Hep C. And as I mentioned, STI control point of care testing with expedited partner therapy. Public Health has been generous enough to give us GC and CT EPT for our patients, for women to take and give to their partners. But we're seeing a lot of trick, and we're investigating whether to do trick EPT, which is not usually done in our area, but because we have such high rates, that we'd like to explore that. And I think exploring fertility desire and doing some more qualitative work around this issue is really important, because of the number of pregnancies we're seeing in these women, and the fact that of the women who've delivered, only one has kept the child, so and the others have been removed by CPS. So it, again, re-traumatizing for this population. So if we could make some headway with contraception and reproductive health, it would, I think, be very huge for this community. There are a lot of people that have been a part of the She Collaborative and the She Clinic, and Erica's here. I don't know if Monica's here. Erica's one of our nurses. It could not be done, like I said, without Aurora Commons, and really the spirit and energy of Lisa Etter-Carlson, who's in Morocco on sabbatical. But she has really been the force behind getting this together. And DOH has been so supportive, Beth Krutzinger-Perry in particular, and then of course Public Health has been very, very supportive of this. So thank you all. I'm happy to take some questions. No questions. Okay.
Yeah, it was fabulous and really inspiring work that you're doing. One question I have is, can you give us a little glimpse of what you may have seen in terms of the interest among the women for counseling mental health services? I know you've got like this huge number of things you're trying to address, but I imagine with all the trauma that there's also a need for that. How do you go about that?
So the question is about the interest in the for seeking mental health services. It is really challenging. There's actually Sound Mental Health, which was CPC, is now Sound, is actually just up the street. They're not going. And I think it's really because there's a lot of day-to-day just survival. If we could take some of that off, then they could focus on mental health. But only 2 patients are regularly engaged in mental health care that are up there. One is intensively case managed through DESE, and that's one of the reasons. But it's just, I think it's something that they would like, but it doesn't bubble up as a priority from day to day. Yeah, you know.
I'm not sure if I heard you say how old these women were, the age range.
Yeah.
And what the median.
Yeah, the median's 37 for our women. Some of the women have been doing sex work for a while. They're in their 40s and have been doing it for nearly 2 decades. And some of the women more recently are much younger. That there is kind of a new wave as the older women that have been in that area have linked to services and have gotten some transitional housing. We've seen a more influx of younger women sort of taking their place. So the newer patients that we're seeing are in their 20s. Yeah, Anne, I think Anne had it.
In that area?
Yes, there.
I think it was just the availability that if it results in increase on paperwork, has the she clinic helped sort of emphasize
So the question is about needle exchange and utilization of services. And I think there really was a lack, there was a hole there. Aurora Commons was getting needles from public health and People's Harm Reduction Alliance was distributing them to Aurora Commons. So there was a small supply even prior to the cluster identified. And I think that the van up at Licton Springs was, but they were only there twice a month. So there wasn't that, there wasn't enough essentially for that population. So now there's a much more robust presence by public health and distribution of needles to that area. Yes. The question is about the women that are pregnant, how many chose to terminate, and whether they knew that they would lose custody. I think that is never in their mind that they are going to lose custody. I think in their mind, they are going to get clean and they're going to keep the baby. That is what they think. I mean, that's what they want. And whether that translates into actually happening is really tough. We're lucky that we do send women to the Swedish Ballard pregnancy unit. The ones that we've sent have left. It's really restrictive, and they don't want to stay. And 2 have elected to terminate. Well, 1 is elected to terminate, 1 lost and had a spontaneous abortion. 1 moved to Spokane, and that's how they were able to went into treatment literally 2 or 3 weeks before delivery, and kept the baby, went to Spokane with family, and still has the baby. So had to physically leave the area. Yeah.
Trisha, can you give us tips as healthcare providers when women like the ones you're working with do enter the healthcare system, the more traditional healthcare system, what we can do to not convey the judgment and the experiences that they've had?
I think, what's been astounding is that people actually don't just say, I'm sorry this happened to you, like in a sexual assault. One of the advocates actually went with a woman to the ED, even here at Harborview. And if that happened to anybody, that would be our natural inclination. But to these women, it doesn't happen automatically. That they're just saying that actually goes a long way. I think it's astounding if you were to look and see those interactions and how unintentionally judgmental they are. There's also, when they're seen in acute care settings, it's always challenging when they have high opiate needs and their perceptions that they're just being treated as a drug addict. When they're seen in the emergency room setting, for instance, they usually inject right before coming because they know they're going to withdraw. And then they're perceived as just, high on heroin and we can't really get anything out of them. And then when they start to withdraw, there's a delay in treatment of that withdrawal. And that is one of the main fears why people don't come in. But I think, just getting back to my first point, just expressing compassion about when they have a problem. There was another woman who went to Northwest with this huge abscess, and at no point were people just saying, you know, I see you're in a lot of pain. The acknowledgement of that, of her experience, it was just not there. Yeah.
One practical question, is it, because they are interfacing, it sounds like, with other healthcare systems and ERs, how do you do the record keeping? Are they more analogous to like the STD clinic and a public health record, or are they more like the satellite clinic and getting Harborview?
Oh no, yeah, so our medical record keeping is all through Epic, through Harborview. There's a SHE clinic visit, a department, so that's all separate, but it's in Epic. So anybody in Care Everywhere can see our notes. Yeah. So we are currently on Wednesdays. Our current hours are on Wednesdays from 10 we get there. That's when Aurora Commons Day Space opens. But we don't really start seeing anyone at that time because nobody wants to rush into the van. They want to use the bathroom. They want to make some breakfast, hang out. And that's our opportunity to connect with ourselves as staff to talk about sort of who we need to reach out to, but then also just have casual conversations with people and check in. One of the things I learned is if you just say their name, it's so humanizing to them, and it's such a connection that we make, just going up and saying, hey, Heather, how are you doing today? What are you gonna have for breakfast? Or, just casually talking to them. And then our clinic, usually we will see anyone if they want to be seen between 10 and 11, but usually it doesn't get going until 11. And then we see people literally until the van is driving off. And sometimes we'll just see people on the sidewalk or in the back of Aurora Commons if there's still people who want to be seen. So we try to be flexible. And then we're trying to expand to Thursdays when they have a brunch at Aurora Commons to see people there. One of our nurses, Monica, goes there on Thursdays just to connect with women. Yeah.
Great talk, Sharisha. Really fantastic work. Have you asked any of the women if they would be interested in long-acting injectable ART or treatment or for PrEP or something like that available, and do you think would be useful?
Yeah, so Bob Harrington's asking about use of long-acting injectable treatment for HIV or for prevention. I think, yes, that would definitely be an interest. The women that are positive, we've really tried to connect them with Max because Max has so many more resources and than we do. We just have one medical case manager who's phenomenal, Charisse, but we don't have incentives, and she's not an HIV medical case manager. So she's really one of the PAR, persons at high risk case managers. So we try to get them to Max as much as possible. And I think that is, an option that Max is waiting for to treat many people. From a prevention standpoint, I think it would be excellent if we had a long acting. I think the delivery of PrEP is still into PWID who are not MSM. We're still trying to figure out how to optimize that. And I know public health is really working and doing some key qualitative interviews with people in the community to try to see what is the best way to deliver it. Because as I mentioned, traditional models of healthcare delivery are not going to work for this population. So how do we get PrEP uptake and then also adherence? And I think long acting, if they're coming in, once a month, once every whatever to get it, that would be a great use of it. And also kind of tying it to opiate agonist therapy in some way. Well, thank you, everyone. Yeah.
The overlap sort of this, so the women who exchange sex are the main. How many women do you see that are not exchanging sex but are injecting that come to the SHE clinic?
We do see probably about 10% of women, yeah. But some of them still sometimes exchange sex, so it's really hard to.
I see. And what if you have women who are just homeless, but have they come in as well, or is that enough? Yeah.
Yeah, we do.
Yeah.
Almost all.
That was great.
I felt like that was all over the place. It was awesome. That's what I could. I was so great.
No, I was like, I'm just using everyone else's data.
No, no.